Good afternoon, everyone. Thank you for joining us for our Health Equity Workshop during our Days for Our People. I am Dora Muhammad, Engagement Director, as well as our Health Equity Program Manager. So I'm very excited to be with you this afternoon, and I'm even more excited for some of the people that I do this work with who have accepted my invitation to join me. You can invite people, but they don't always say yes. So thank you for your time. Honestly, each one of these are so very special to me. So I'm going to introduce everyone, give a brief overview of sort of how I shape the um, workshop real briefly, but really this is an opportunity for you all to hear from people that I do believe are leading in health equity work in very innovative ways and how they approach this work. And so I wanted to really have you all hear from them. The key link for all of them is that they center the community in their work, which is very, very important. And I will spotlight when I call each person out, and then you will hear from them in this order that I introduce them. We have with us Reverend Perez Gatling. There he is. He's the pastor of Ebenezer Baptist Church in Virginia Beach. We have Dr. Allison Ansher, who I worked with for a few years now, because where I live, she's the director of Prince William's Health District. She literally is in every single coalition meeting that I participated in. So I see her in the community all the time when I tell you. Love her. Next, we have Ali Farouk. He's one of our board members, so as a disclaimer, but still he's just a good champion for healthcare. He is the public policy director for Families Forward Virginia. Beautiful, beautiful work that he's doing on the front lines during the pandemic. And last, but absolutely not least, but the best and the greatest, Chloe Edwards. Love her. Yes. She's a policy analyst at Voices for Virginia's Children. When I say innovative, creative, brilliant, absolutely amazing in how she formulates her approaches and the networks that she wants to do. So she'll be sharing some work that she's involved in one of the working groups. And so broadly, all of us collectively, if you will, in my mind, we like, and here's the other thing, we also sit like on part members of the Healthcare for All Virginia's Coalition. And so we interact on so many different levels, and we look for ways to support one another. We look for ways to partner. So that's why this conversation to me is really important, because there's so much work to be done, but we do it so much more effectively when we do it together. And so today, really focusing, the pandemic, if it taught us one thing, because we wasn't traveling a lot, we really look to your neighbors. You really look to your community. You really looked for resources and where you can get help that was within your arm's reach. Within healthcare settings, this is very important to center the community. And so that is the theme for today's workshop, centering community in healthcare. So with that, I'm going to spotlight, bring back Pastor Gatling. He's going to talk about a partnership that his congregation has worked with the Eastern Virginia Medical School. He's a part of our JAB initiative. And I promise you, the very first conversation that I had with him, I didn't want it to end. And when I first began at Virginia Interfaith Center in 2018, and I told him this is one of the reasons why I really, really wanted to connect with him, he would have members email me. Well, he wouldn't have them, but I don't know if I didn't think he was aware. Members of his congregation would email me and say, hey, my pastor said so-and-so, you're doing this. We want to help. We want to amplify you. You did this. I want to do a video for your announcement. Like they were just doing other stuff. And I was like, okay, thank you. Thank your pastor for me. So again, he champions this in the pulpit. Love this brother. Pastor Gatlin, it's all you.
Good afternoon, everyone. And now I'm not sure whether I can do this for 10 minutes. Of course I can. I'm a pastor. Right? I can talk for an hour. And I thank Dora for this opportunity. And as you can see behind me, I am a bivocational pastor. I am a high school English teacher. And I've got 2 more years until I retire and a pastor full-time, and that's my plan. And if God has another plan, I'm sure he'll show me the plan before that time. Um, the about clinic Beyond Clinic Walls program that we participate in with EVMS. One of the, and let me give you just a backdrop. We have a number of organizations that send people into the community and into the churches for one-shot deals. We have organizations that yeah, of course, get they get grants, they get funding, they come into the church and they want to educate our people about high blood pressure. They're there for an hour and they wave goodbye and we never see them again. And so when EVMS introduced us to the Beyond Clinic Walls program, my big thing for Dr. Romero was that if you're not gonna stay, don't come. Because I can play a video on high, and this is where the real me comes out. I can play a video on high blood pressure and then for an hour and then leave, and I could probably find the answers to their questions within the FAQ section of whatever video I show. There was no need for them to continue to come to us to provide this education without providing some kind of remedy, some kind of service, collecting some data, and then circling back around to see how effective the education and the programming was for our folks. Them just coming and telling us stuff was not helping our community. And I pastor Ebenezer Baptist Church in Virginia Beach. And my church is right across the street from Virginia Wesleyan. And so my church is in a densely populated community of people who live below the poverty line. And there are lots of organizations that will come in and do one-shot deals for people in our community. But again, if you're not triangulating the data, if you're not coming back around, if you're not looking to see, looking to form a long-term relationship with us and collecting data to see how your presence has had a positive impact on our community, then it's all for naught. And so we partner with EVMS and Dr. Cynthia Romero with the Beyond Clinic Walls program. And I will read their definition of what the Beyond Clinic Walls program is. Beyond Clinic Walls is an innovative outreach initiative that started with EVMS Glennon, the EVMS Glennon Center for Geriatrics in 2010. And it is a student visitation initiative supported by the Students for the Advancement of Geriatric Education and Community Engaged Learning. And Beyond Clinic Walls collaborates with partners like Senior Services of Virginia and local churches to recruit participants and to ensure that their education and their programming improves the lives of the people who are participating in the programs. And so the various programs that are a part of the Beyond Clinic Walls initiative, they have one of the pathways is nutrition and exercise. Another pathway targets older adults and the chronically ill. Another pathway deals with mental health. Another pathway, bystander CPR and first response, community stroke awareness and first response, health equity and environmental health research, health and justice, and that deals with mental health, hospice for older adults and the chronically ill, LIFT deals with nutrition and exercise, And medical Spanish deals with global health equity. Mother and baby mermaids, health equity for expected mothers. Refugee health, that's part of global health, and Revive training is a part of global health. And they have a program that deals with street health, and that's a part of health equity. And then they have one, part of that deals with children, 757 We Care. And we're starting the program with EVMS dealing with our seniors. And COVID has thrown a wrench, a monkey wrench in part of our plans, but they have created a form, EVMS has, and it really is a long-term initiative where they have to build trust with our seniors. And we're talking about their medical students and their residents, and they build trust with our seniors. And we're starting with our seniors, because if our seniors catch on and they begin to spread the word, then seniors from other churches and our younger people will gravitate toward the program. And what do they do for our seniors? The first session was dealt with health, nutrition, and eating right. But in building those relationships, we want our seniors to provide them with information. And part of EVMS's programming for the older adults involves them analyzing the medicine that our older adults are taking, their prescriptions, to see whether one prescription is causing something, or these two prescriptions together are creating another condition. Another part of that is, we haven't started this, but we're moving toward it, and is part of the program. They will go with, they'll have medical students who will go with our seniors to the doctor, who will accompany our seniors to the doctor. And because in our initial meeting, I talked about my seniors who will not advocate for themselves. The doctor will give them a prescription or provide medicine for them. They will take the prescription, take the medicine rather, and if they don't feel better or if it makes them feel worse, they'll just stop taking. They won't call the doctor back to say, do I have another option? Here's how this made me feel. And then they won't chronicle how it made them feel, and they won't do a diary. Let's see, did I take it with food? No, I took it on an empty stomach. That might be the issue. Or did I take it at the same time I took my other medication, and which other medications? Those conversations, and they're not doing that metacognitive kind of activity to where they're thinking about their own thinking processes, and they're looking at why medications make them feel the way they feel. And so EVMS, part of this Beyond Clinic Walls program, they will go with our seniors to the doctor and have those conversations with the doctor alongside and at Paracletos with our seniors, because the plan is for them to build that trust with our seniors. The same person that this senior deals with, they'll deal with for a while and build that trust. And once they built that trust, then it becomes, okay, I know you've taken on a new medication. How does that make you feel? Do you feel comfortable talking with your doctor about it? If you don't, then when we go to the doctor, well, I'll go with you and I will express what you have told me. And so that's a little bit farther out, maybe 6 months out, if we can get the COVID numbers down so that we can meet face to face. But our goal is to get data at the beginning, and then along the way, get data at checkpoints to where when this senior maybe initially signed up, or this person signed up for the program, they were suffering with maybe 3 or 4 conditions on a daily basis. And then what we want to see over time is that because of the education, because of the advocacy, and because of the work that EVMS is doing in our community and with our folk, that maybe in time, maybe they're only suffering from one condition, and that may be occasionally. We want to see real outcomes, because again, if we start with this one group and they give EVMS the green light, or they give EVMS a good report, then what happens is that the next group says, okay, my auntie trusted them in doing this and trusted them. And so I'm going to give them this data because I trust them too. And we know that there is mistrust between the Black community and the medical community, but we also know the church is the place where if we allow the medical community to come in, then they are vetted on a particular level. And we saw it when the pandemic began with tests. In terms of COVID tests, and we were working with Centera, they gave they allocated 150 tests to Tidewater Park. 4 people took tests. They allocated 150 tests to my church and Enoch, and all of the tests were taken. All of the COVID tests were taken. So you have to go through an organization in order to get on the inside, and EVMS has done that, and we are certainly going to hold them accountable, because they're not just going to, like I tell politicians, and I'm done, politicians can't just come in our church, talk, and then leave and never come back. Nobody gets the right, and this is me being the real me, nobody gets the right to hit us and quit us, okay? They got to stick and stay, and if you come into Ebenezer, then you're in for a long-term relationship. Are there any questions?
I love it. We'll take questions at the end. Hold on, I don't want to get everyone out, but you hit all beautiful points: real outcomes, trust building, generations, the role of the faith community. I love it. And so here to add, really to build on what you're saying, what you just shared, Dr. Ansher, again, very focused on the trust building element in the community. She is very much so. So you have the floor, Dr. Ansher.
Yeah, hi, I'm Dr. Ansher. I'm the health director for the Prince William Health District. I cover Prince William County, Manassas City, and Manassas Park. COVID hit the Hispanic Latino community the most as far as cases, hospitalizations, and death. And a lot of the reasons that there was so much transmission of disease, we knew before COVID happened that something like this would impact that community because of the multi-jurisdiction generational households, the large number of people that may live in a household, the fact that the older generation were more susceptible to having bad outcomes from the disease, and culturally because they care for each other, and that's an expectation. So I enlisted the Centers of Disease Control to come out, and we actually did a door-to-door survey to understand what the issues were in the Hispanic Latino community that makes it difficult for them to take advantage of resources in the community that the community has to help support them if they have to isolate or quarantine, as well as why they were getting very ill before they would go for health care, as well as were they getting the information that they needed, and was it in a way that they could understand it. So we went door to door through various Hispanic Latino communities in the Prince William Health District. Prior to that, we engaged key community leaders in the Hispanic Latino community to find out what they've been hearing, what things that we need to consider, what things could we bring to benefit them, such as hand sanitizer, face coverings, things that they knew would be helpful but couldn't necessarily afford. And many of them, of course, because of legal status, were uncomfortable accepting health or from the local governmental agencies for obvious fears, and actually also wouldn't take it when we got testing, didn't take advantage of the testing because they have to sign up and provide some personal information that they were very uncomfortable doing. Same things happen for vaccinations. What we found also is that the information from the CDC was very, it almost made them feel bad for what they were doing. First of all, a lot of them could not afford not to go to work in quarantine. How were they going to pay the bills? How were they going to feed their families? Would they lose their job? And those that got ill would stay home, continue to work even though they were slightly ill, putting themselves at significant risk of getting very ill, ending up at the hospital and going home with oxygen, or unfortunately not going home. So not only was the information from the CDC made them almost feel guilty for not social distancing, not caring for their loved ones, going to work, etc. It also often was at a higher reading level, or not a way that they could take in information in the limited amount of free time that they had. They preferred more pictures, less text, get down to the point. And so one of the things we did was we took the information from the CDC and gave them options where they could make their own decision. For instance, how you separate in a household, what was low risk, medium risk, high risk, and for driving in the car with other folks, for what things to do at work, face coverings, hand sanitizer, etc. Also, many of their employers did not allow them to social distance at work, as well as there was some machismo as to why they did not accept the face coverings. So after we developed this information sheet to give them options to make their own decisions as to what risks they could and would take, we first put it through a Hispanic Latino key holders group to give us input. And then we actually took it to the community to get input on the information to improve it. And then we were lucky enough that a local hospital used their skills of developing a very professional looking handout or flyer in both English and Spanish. And we were able to put it in equity bags as we went canvassing door to door in those communities to provide them information about COVID, provide them hand sanitizer, provide them also face coverings. We ended up hiring people from their community as community health workers to go into those communities and to educate them and to encourage them to reach out to some of the resources. As time moved forward and we had vaccines, the same folks did not go to go for vaccines. They didn't feel comfortable going to, first of all, signing up again. where a lot of their personal information was required in the when they signed up for a vaccine, as well as the times that places were open, the more larger vaccination sites were open. Wasn't convenient for when they work 6-7 days a week, from 6 in the morning, perhaps, or 4 in the morning till 6-7 o'clock at night. And so during H1N1, we had, the health district had gotten a small clinic on wheels to use to vaccinate for H1N1, the flu, the pandemic flu in communities. So we now have what we call a community engagement team. And what that team does, we get input from the Hispanic Latino businesses, input from those key stakeholders. There's 2 particular mobile home parks that have incredible people who are their management that advocate for their residents, and they are on this committee and they've reached out to us. And so what we've been doing is taking this clinic and going into the communities. We first have our community health workers canvass the neighborhoods a day or 2 before. We're going to be there to provide vaccinations, to talk to them about COVID. We also have been providing Narcan and revive education, because that was something that the community felt was useful. Narcan is used to prevent overdoses from opioids, because as we all know, we've seen an increase in cases as people are more together during COVID, and care for substance abuse has not been as available due to COVID. We've also provided them other information on resources, and what these canvassers have been able to do is build the trust, get people signed up for these vaccine appointments, as well as, we take walk-ins, as well as just with the education, these folks walk in and are getting vaccinated. Right now, the Hispanic Latino community actually has, number-wise, the greatest number of folks vaccinated, at least with 1 vaccine. And a lot of it has to do with using these key leaders to tell them, to provide education to them that we've also provided to them. We've had a town hall meeting where a clinician from the community who's well respected and bilingual worked with us at this town hall meeting where we answered questions. We found that not bringing people together, but we got more people, particularly with COVID, allowing them to do it virtually, a lot more than we ever expected to. Additionally, the trust that's been built between the canvassers and the communities that they come from has been invaluable, and has helped this community get vaccinated, has solidified our relationship from the health district with these communities, which we had never really been able to, or honestly taken the time to dig down into these smaller communities to develop the trust. And so we intend on building on that trust, building on the trust with the key stakeholders on other health initiatives.
Sorry, as we explained earlier, Dora has stepped away because the bill that she is providing testimony on is up. So she'll be away for a bit, and I will just be here to help you with any technical support you need, but please continue with the conversation.
I'm not sure who is supposed to go next, but Dr. Ansher, you're all finished?
Yes, I was going to suggest, Ally, you're actually next.
Oh, okay. All right. Well, good afternoon, everyone. My name is Ali Farouk. I work for an organization called Families Forward Virginia, and I'll keep my remarks really brief. I think my Pastor Gatling and Dr. Ansher have talked about are really important, and just want to touch on a few of those things. Families Forward Virginia is the Virginia chapter of Prevent Child Abuse America, as well as the state office for several home visiting programs. And so home visiting, if you're not sure what that is, those are programs around the Commonwealth, and Dr. Ansher is probably familiar with one. There's a Healthy Families program in Prince William County, but around the Commonwealth, that basically someone actually visits your home uh, while you're pregnant, after you have a child, and does some of the basic things like helping you understand child development, helping getting you connected to services, doing some basic screenings. And it's one of these evidence-based programs that we found that really produce really high quality outcomes. And the reason we think these services are important, because again, going back to what Pastor Gatling and Dr. Ansher said, when it comes to health, when it comes to improving health, we are people, right? It seems obvious, but it's not just about creating widgets and giving people things and then magically people get better. We work in community, and that community needs trust and relationships and social connections. And that's how we grow, and that's how we survive and thrive. And so that's a huge part of health work. That's a huge part of public health work. And so one of our key things in our understanding at Families Forward Virginia of how to strengthen communities, strengthen families, is that we know from the public health research that there are some things that parents and children need to succeed. And there's different ways of talking about it, but I'll just give one example. The Center for the Study of Social Policy talks about strengthening factors or protective factors, things like parental resilience, social connections, basic knowledge of parenting and child development, concrete support in times of need, and social emotional competence in children. This is one way of looking at it. The Centers for Disease Control has a technical package out where they talk about the protective factors to prevent child abuse, and they don't use exactly the same language, but it's a lot of the same things. They talk about, family economic support. They talk about parental resilience. They talk about basic understanding of childhood development. And so that's why one of the things we're advocating for at this General Assembly session is a budget amendment to allow for more funding for home visiting programs, because home visiting programs such as Healthy Families, Parents as Teachers, down there, Pastor Gatling, where you are, CHIP of Southampton Roads, Nurse Family Partnership, these are some programs there. They are doing those things, they're providing those health services, but they're doing it in ways that build trust. Because like folks have said, you can't just parachute into a community and be like, hey, here's how you identify this disease, or hey, here's how you can be doing this at home that's different. You have to build relationships of trust, and then you have to be present. And that's how you help folks grow and thrive. And so home visiting programs, again, we're in those communities, we're building relationships based on trust with parents, with communities, with organizations, and we're there helping folks navigate through just life. We're there helping make sure folks are connected to the services that they need, whether it's a healthcare service, early childhood, housing. And that's really where I think we need to be talking more about when it comes to strengthening families and communities. So that's one thing we're advocating for, is more funding for home visiting services. The second thing is family economic support. And we, even though we're a public health organization, we have seen the last several years, not even the last several years, last 30 years, we've seen families struggling more and more to afford just basic necessities. When you look at child abuse and neglect statistics, neglect is by far the biggest one, and that's where a lot of families just don't have the basics. They don't have housing, food, transportation, healthcare, childcare, things like that. These things, of course, have become increasingly expensive for everybody. And we're now seeing, especially around housing, we're seeing that being a huge factor to contributing kids going into foster care, the lack of housing stability, and also lack of housing stability puts children at high risk of physical abuse, sexual abuse, sexual assault. And so again, another thing we're advocating for is direct economic support for families. We're trying to highlight that, hey, providing safe and stable housing, that's a public health issue. Making sure that kids have a place to sleep, have a place to grow and feel safe. That's also a school readiness issue. If a child isn't able to live and grow in a safe space, that they're constantly moving every year or twice a year, that's not gonna, you're not gonna see them succeeding in school the way they can. And so these are some of the things that we're trying to uplift, that we need to really create stronger communities, that none of us is an island, that it takes a village to raise children. And unfortunately, I was lucky to grow up here and I had my mom and dad here. I had some extended relatives, but there are some folks who, for whatever reason, maybe you're in the military, you don't have your extended family around. Maybe you've escaped abuse and you don't have good relationships with your parents because of that. That doesn't mean that you can't create family and can't create some community of support around you, and all people deserve those things. And if we want to really look at these alarming public health trends, if we want to really address the dramatic rise in depression, suicidal ideation in youth, we want to look at the dramatic rise in substance use, these are diseases and issues of despair, and we can absolutely address them. We can create communities of support. Home visiting is one of those things. Other folks have talked about other services, but helping families afford the basics, and then as a community, teaching them about childhood development, teaching them about safe and positive parenting, helping folks break those cycles of abuse and neglect that I'm sure Chloe's going to talk about in more detail. That's how we really think about these issues. That's how we think about maternal health, public health, children's health. And so really appreciate all of you advocates being here, and happy to be part of this panel. Thank you so much.
Thanks, Ali. So I'm sorry I had to jump off to go make comments. Clearly you see the thread of educating, empowering, but again, trying to have each speaker build on what the other one sets up. So when Dr. Ansher was sharing about literally the different models of going into the community and making the community a part, well, Ali's work takes it further and going into the actual homes of people, and how empowering is that? And so last up is Chloe. Hi, Chloe. Okay. There she is.
And so
She's going to talk about the community health workers, which you've heard mentioned several times already. She's a part of, she'll probably be humble. This young woman here is a part of so many moving, like change making and different groups. So she's part of the, let me get it right, the community health workers. Is it a working group or council?
Community Health Workers Advisory Development Council, but I'll get into all that lingo. So hi, everyone. I'm Chloe Edwards with Voices for Virginia's Children. I'm a policy analyst at Voices. Before that, I was advocacy and engagement manager. Before that, I was an outreach coordinator. So I've definitely been in a few different positions. I'd say what guides my work is primarily, I look at my work with the lens of a community member. I was led to do advocacy through my own lived experiences. Participated in an advocacy day at Voices a few years ago and told my story of having experience in the foster care system. So that primarily is what guides my work, as well as my identity as a Black woman and survivor of trauma, witnessing systems fail families. And so with that said, I work on the Racial Truth and Reconciliation Virginia campaign at Voices, and lead our public health and social justice work, where our campaign mission is to empower historically marginalized communities and acknowledgement of truth to promote healing, reconciliation, and social justice for children, youth, young people, and families across Virginia. And we do this through a lens of looking at trauma-informed care and policy, equity, which is the redistribution of resources, but then recognizing, well, people need different resources and different amounts of resources because all people are not innately equal. And so eliminating the barrier so that all people can be equal, to me, is ultimately justice. And so why community health workers? I'd say if I could look at the work that they're doing, it's not necessarily new. There's been a lot of research studies on the impact of community health workers. Several other states have invested in legislation and supporting community health workers. But we talked about trust a lot earlier in this panel. And when we talk about community health workers, to me, the key piece and why they're so effective is because they are from the community. If you're a part of the Development Council, you know that they stress maintaining the spirit of the community health workers, so not putting outrageous guidelines on community health workers that would disqualify from them with, being a part of the community. And then they also provide culturally appropriate services. So while we talk about cultural competency a lot, that does not equate to culturally appropriate services. And we know that in our systems, in particular, there is an underrepresentation of professionals of color in some healthcare settings, such as your doctors, et cetera. And so we often look at that very systemic institutional level Or in our healthcare sectors, we look at that person-centered lens without acknowledging the way in which our systems perpetuate inequitable health outcomes. So when we look at community health workers, they apply their unique experiences in the community, their language, their culture to their work. They're trained in a variety of community settings. They're in your pharmacies, they're in your perinatal settings, working with mothers and infants, and they're also in your healthcare settings and et cetera. And I'd say they're also in non-traditional settings. When we look at public health, healthcare access, if I'm trying to quote it off the top of my head, is literally just about 20% of your overall health. And so looking at where people live, work, and play, and how we can impact those communities. Now, we've seen throughout the pandemic, regardless of this education we're putting out there, people do not want to use our systems and our services. And I think that supersedes education, right? Because we can educate people, but if they don't trust our systems, why use them? And this goes back to, I mean, long-standing inequities. We could go back 400 years ago. It goes back to slavery, the Indigenous Trail of Tears, the forced sterilization of Hispanic and Latino communities. It goes back to the Tuskegee syphilis experiment, where Black men were experimented on for 40 years when they could have been cured of syphilis. And it goes back into even our gynecological systems when we talk about right here in Richmond, Virginia, VCU's participation in research and experiments through grave robbing. And so this is why the education isn't working, you know, because it goes way, way, way back. Now, when I talk to people in my community and the impacts of COVID-19 and why people are not trusting the vaccines, et cetera, it's because they're witnessing all these disparities. Well, why is it that Black women are more likely to die during childbirth than white women? Why is it that, et cetera? And that goes back to the root causes of inequity, which is racism. So community health workers, they provide community mobilization and outreach. They provide health promotion and coaching. They also serve as system navigators. If anyone has ever tried to get through the system, even working in the system, creating, contributing to bills and laws, I have difficulties navigating our systems. And so they provide care coordination as well as case management and even participatory, community-based participatory action research, which is the best practice. Oftentimes we are in these settings, sitting on these work groups, and community is not present to inform their own autonomy and their own health outcomes. When we look at age demographics that community health workers serve, it starts, according to a 2021 survey from the council, 20% children 0 to 5, about 18% youth 6 to 18, about 59% young adults 19 to 25, 58% adults 26 to 64, and they do also serve your elder senior population over the age of 65, about 44%. And so they do serve across a lifespan, and as well as cross systemically. So in each of our systems, when we look at where people live, work, and play, and how we contribute to better health outcomes, it's your neighborhood environment, access to healthy foods, quality of housing, crime and violence, impacts public health. What are the environmental conditions? Is there some sort of plant nearby that's emitting toxic waste? It goes into health and healthcare. So your relationship with your primary care provider, access to health insurance, health literacy, social and community context. And so this goes into civic participation, social cohesion, discrimination, and this includes racism as a part of a public health lens as well. And then public health also looks into your education and your economic stability, like food insecurity, housing stability, et cetera. So it's quite innovative to really look at how we can further invest in community health workers. If I had a bucket list, it would be looking at non-traditional ways that Medicaid can fund intersectionally across systems, public health prevention, And so I'm interested to see how we could use Medicaid reimbursement or compensation models for a non-traditional providers that are contributing to preventing community violence or combating community violence. Looking at, for example, your community-based organizations who may not be a doctor's office, but may have a community health worker, and looking at non-traditional models to fund that. And then ultimately, when we look at our systems, it's often we're telling people you're the reason you're not healthy. If you fix your behavior, right, then all of a sudden you'll be healthy, but we're not recognizing how to hold our own systems accountable and how we're failing people across the different health spectrums, because we're looking at health with, well, you have access to healthcare, right? And so you should be healthy. And that's not how public health works. And so I'm not a community health worker. I'd say I'm a cheerleader for community health workers and a champion for community health workers. But currently the Institute for Public Health Innovation or the council has been awarded close to $4.3 million in partnership with the Virginia Department of Health to host collaborating partners to scale up CHW infrastructure in Virginia through the Community Health Workers for a Healthy Virginia. And so we're hoping that this will further inform, like, what does this scaling up this infrastructure look like in Virginia? There's a lot of momentum around community health workers. We know that should we really push in the GA for community health worker investments, this may mean challenging, standards or creating more strict guidelines. And so this is something that we know the Virginia Department of Health has worked with the council to make some recommendations that have not been passed by the General Assembly, but really what we're hoping is to maintain the spirit of the community health worker, making sure we're not requiring like a college degree, for example, and just a whole high school diploma so that they can truly be from the communities that they serve in. And so with that being said, we're not tackling any investments in General Assembly funding for community health workers this year, but there are some other studies that are being done that looks at how we can continue to collect data that's rooted in social determinants of health or public health frameworks. There is a study that's being introduced this session around looking at a community violence pilot. And so in the future, we would like to just explore more what we call value-based care models, which looks at healthcare outcomes, holding our systems accountable, but then also looking at non-traditional ways that Medicaid can fund not your common healthcare settings. And so with that being said, I'll pass the mic back to you, Dora.
Thank you. Amazing. So I'm going to pull everyone in a couple of things for a couple of questions. There was one question. Well, there goes Ali already doing it. I was going to say that everything that everyone talked about will have links on our website. Ali already dropped his in. If you want to grab it now, feel free to do it. Someone asked a question about how do we address unconscious bias? Like, are you talking about my life right now? So we have a bill before the General Assembly on that. This morning's plenary focused on that, in fact. So I'm going to drop the link. That's our YouTube channel. You can check out that video from this morning and visit our health equity webpage on our website. It has all of the work that we've been doing around making implicit bias, unconscious bias training part of the criterion where all healthcare professionals who seek a license by Virginia Board of Medicine will be required to take that training. A couple other things I want to point out as I bring everybody in with my spotlight, spotlighted with me to take any other questions or final thoughts from this conversation. Few things. First, thank you to all the panelists. Comprehensively, definitely the themes of trust and building. I wanted to, someone had dropped in how to really deal with trust. We have an entire JAB initiative that Reverend Gatling, we're engaged on.
Perez. Perez Gatling.
And Dr. Ansher. But it deals with, really looking at the mistrust. And so we developed an initiative Because even though we're a part of the state's rollout for education on the vaccine, when it hit that plateau and everyone was like, well, how do we overcome the hesitancy? If we did not address all of the historic harms that's been done to communities of color by the medical community that Chloe outlined, where there's COVID now, it's going to raise its head again with another health crisis. We have to begin to speak to that. And so we did a 3-part Jab Talk series in the fall that literally addressed each one of those. And the Jab stood for justice, autonomy, and beneficence. And and we took the conversation to introduce principles of ethics that should be really amplified in healthcare. And which is a perfect segue for this, because after we did sort of the education piece, for the next few months, what we're going to be doing in the JAB initiative, and why I wanted these beautiful healthcare advocates and professionals to join me today, to show their models. What I hope to do, and I've always tried to do, is say, here's a model of what good healthcare delivery looks like. Then you should look into your community, look at your health department, look at the congregations in your area, and try to replicate it and duplicate it across the Commonwealth. And so I always try to identify things that really are ideals, really are best practices, things that we should be supporting throughout the Commonwealth, not just in the small corners. And so again, I'm blessed to have a Dr. Ansher in my county, but you all need to have a Dr. Ansher. Go find your Dr. Ansher, go make a Dr. Ansher. Do you see what I'm saying? And the same with Reverend Gatlin. He's such a light for men of faith, for leaders of faith, for faith leaders. I plan on having him all across the Commonwealth. He don't know yet, but it's just a model. And you need to have people that really love what they're doing. And if you did not hear it in each of these individuals, that's what they are. And so there's different levels. To be quite frankly, all of my advocacy work around maternal health the past couple of years, so many women are like, can you be with me when I deliver my baby? Because you really do have to empower people to advocate for themselves. You heard that in everything that these 4 shared. So over the past few months in the fall, I became a trained doula. Just because I was like, okay, women want me to be there, I'm gonna be there, but I'm gonna make sure that I have a right to be there. I'm gonna be there. And so we have within our Healthcare Hope program, Healthcare Hope ambassadors. So if you want to push your advocacy deeper and really work to really replicate what you've heard today in your community, I definitely encourage you to join the ambassador network that we have here at the center. And then last but not least, stay engaged with the center. Stay engaged with the health providers stay engaged with your health system in your neighborhood. Stay engaged with other healthcare advocacy organizations. And so I wanted to see if there's any other questions. So that's my 5 cents on what to do next. People was like, well, what do we do? What we learned today? That's what I want you all to do. Any other questions? Okay, let's see. I haven't been keeping track. I don't know if Aisha, are you still with us? Or she has 5 hats on right now, I'm sure. Ali says, for unconscious bias, we have to change policies and require attention to how this affects the delivery of care, but also this is individual work we all have to keep doing. It's a process of learning, unlearning, and looking inward. Chloe, the Joint Commission on Healthcare Study of Benefits of Hospitals.
I was just dropping a few those. It's gonna take a while.
Okay. Yes, okay. I'll pull it and send it out. You're the best. Thank you.
Dora, can I say one thing?
Absolutely.
And that is on unconscious bias and tackling systemic racism, especially in our healthcare system. It's not possible to change those policies until you address the fact that some people believe, well, I don't hate Black people, so there's no problem with these policies, because on the face of it, they're not racist. And there are really good people who love their non-white neighbors and friends and colleagues who believe that. And that's what I'm saying. You have to do both. You have to keep challenging the policies and talking about the disparate outcomes. But everybody, every single institution, every single individual, whether you're white, Black, it doesn't matter, especially for those of us who are minorities that are not Black, you have to go through that individual process and do that work of learning and unlearning the biases, because we all hold it. And this is what I tell people, even in my organization. I've literally worked for civil rights organizations and done systemic investigations in lending discrimination and housing discrimination. And I am still unlearning racist ideas that I absorbed over my life. We all have absorbed it. I think there's this idea out there that I'm not an evil person, so I can't be racist. And my answer is we're all a little bit racist. Some of us more than others, but we've all absorbed it. And so you have to do both. So if you're a hospital system, you're a practice of physicians, or you're a nonprofit, even those of us who think of ourselves as justice oriented, yes, we all have absorbed those attitudes and have to do that individual work in order for the systemic work to be successful.
But I also think that we need to do a better job of encouraging other ethnicities and races to go into the healthcare profession, become physicians. And I know there's the concern that you can be, for example, African American and get trained in hospital X, and you're trained to sort of see things like a Caucasian person. I think we're at a different time now. I think that having more people of color in healthcare, where people can identify with their provider, talk frankly, perhaps have had the same, maybe not, but the same stressors that perhaps their patient has, that they can identify with and see that they can be anything anybody else can be. I think that helps with the racism against, yes, they may still be racist in some way, a little bit, a lot, against other races, other ethnicities. But it will, I believe, improve the health of the races and ethnicities that they represent. So I think it's, yes, it's systemic, but I don't think it's impossible. I think we need to teach our young kids that they can be anything they want to be and support it. And whether it's through mentors or whatever, and support it. It's sort of, as you see more women going into STEM, more young girls, I should say, going into STEM, something that perhaps if they weren't encouraged, perhaps if they didn't see models like them, may not have happened.
Chloe?
I'll give my 2 or 3 cents. When we talk about equity detours, we're often inclined, for example, what I would refer to as the cultural fetish. So, we're trying to train through cultural competency or look at proficiencies as it relates to culture, but these programs tend to name the issue of racism rather than offer solutions. And I'm a fan of cultural competency training, but we also have to recognize where it falls short. There's also the individualizing detour. And so that's when this innate inclination to go into the individual and the interpersonal forms of racism. That's where we get the implicit bias trainings, training on microaggressions or even white privilege. But this is often, we're looking at the individual biases and actions, and we're ignoring the institutional conditions. And so I think too, when we look at structural racism, it is the way that systems, institutions, organizations, people, and the individual all plays a role in maintaining racism and the inequities and the outcomes that we're witnessing in society. So that is a very multi-layered approach, which is why a lot of people run away from social justice work. And so these are the policies that we're going to have to continue to introduce in the future, because even when we talk about workforce, that's once again another issue with racism. How do we provide systemic incentives, loan repayment programs, et cetera, to get more doctors, physician assistants, et cetera, in healthcare? And once again, that's another institutional problem. And so there's a hurdle every step of the way, but I think we have to look at it through that structural framework of racism. So how are we curing the systems, the institutions, the organizations that maintain and perpetuate racism, as well as individuals, and how other individuals influence and interact with people, which is interpersonal racism.
Really, you just defined critical race theory.
I will
I'm
say
a big
that.
fan of critical race theory and critical social theory, but we won't say
Right.
that word today.
Right, I mean,
Right.
you just defined it.
Mhm.
And one of the problems is when people come in
But
and pull out
Perez, before you
community.
go, I want you to know you're going to have the last word. So after you give your thoughts, you're going to wrap it up. I have a 3 p.m. workshop, folks. So just
Oh,
know.
okay. And
You are the
I've
last
got a
word.
kid to get back to. And one of the things that we see in our communities is that people come in and tell us what they think we need rather than ask us what we need. And those are really tough conversations for me, because people think I'm being rude. It's like, but you don't understand us. You can't tell us what we need. And we see that all the time. And that's one of the barriers to us getting what we need from agencies and organizations. We had feeding events during COVID, and we worked with the Urban League to have feeding events. And there were a couple of times when they took pallets of food back to the food bank because they were assuming that food insecurity was the issue. They didn't ask. We were grateful though. Please don't think, but again, they needed other things.
Thank you very much. So again, this recording will be available on the session sign-up page along with different resources and links. So thank you all for joining us. Thank you, Allison, Chloe, Ali, and Perez. Thank you, Aisha, for your support, the wind beneath our wings. And thank you all for joining us. And I hope you really, truly have been inspired to really push for more health equity in your community. And together, collectively, we'll do it in the Commonwealth. Have a wonderful afternoon, everyone.
Thank you. Nice meeting
Thank you.
everybody.